Oh, yeah, got it.
All right, we are now.
Okay, all right. Okay, well, I would like to welcome everyone to this experimental version of the Integrative Diagnostic Medicine Case Conference. It's a little bit different. I think this probably will be the last time that we use WebEx. I think we're going to go to Zoom. Anyway, I want to welcome everyone. Friday, August 7th, this is the way to start your weekend with the case conference. I seem not to be able to move the slides backwards, the arrow keys don't work. So we're just gonna jump right into it with CT warm-up. We always do a warm-up, and here we go. So this is going to be the challenge, and I am not sure if I'm going to be able to see the chats. So perhaps Alex will be able to see the chats, and if he does, well, he will just record your answers, right? And then I'll issue scores for everyone after that. All right, so let's proceed. This is now everyone, one thing, I'm hearing background noise, so if you are not muted, mute now. Very good, good job. Okay, here's what I want. Everyone to identify 4 calcified things in the CT warm-up. Pretty good challenge, huh? Andrea Gilbert says choroid plexus, good job. Well, hang on a second, I was gonna, sorry, be specific. Would you like to be specific about the choroid plexus it's showing? We can be a little more specific. Hang on a second, I just missed a couple of chats. All right, subcortical calcification. That's an interesting misconception. Let's see. I'm just kidding. All right, I was going to go first, and I'm going to start with the cranium. The cranium is calcified. Okay. So, I'm sorry. Who's talking? Who is that talking? Someone was talking. Okay, here we go. Falx cerebri in the midline. So this is calcified falx. All right, everyone pick up on that. The left glomus choroidium. Okay, that's part of the specificity. So I said be specific, right? And there are 2 things that require, actually 3 things that required specificity. The cranium, my answer was perfect. But you could have said just calcified dura or mineralized dura. Falx cerebri is a better answer than dura. And instead of saying just choroid plexus, glomus choroidium, all right, is the perfect answer. And it's actually the left glomus choroidium. But now comes the real challenge. What is that last thing that's calcified? Remember, I'm saying be specific, yes? And the answer is gyriform calcification, Dr. Gilbert, exactly correct. What I'm looking for is oligodendroglioma. That's the specificity, oligodendroglioma. Now, I will accept gyriform calcification or curvilinear calcification. I will give you 50% credit for that. Now, you might say, you could argue, it's not pathognomonic. And I agree. It's not. Okay, I will not repeat Dr. Gilbert's comment. We'll take it offline for that one. Okay, yeah. You can't read my mind, that's fine. Okay, here we go. Let's have a look at that gyriform calcification. Here's a specimen, and what you can see, I don't know if you can see my pointer, it's kind of green, but you're seeing a gyrus with 2 gyri with a sulcus in between, and there's a cauterized vessel at the bottom. And look at this cortical calcification in a curvilinear or gyriform fashion, and this is actually going all the way around the sulcus. That is quite beautiful. This is what we're talking about. Higher power, you can see the individual calcifications, which when they form a conglomerate that's easily visible on CT scan or MR gradient echo would be the optimal sequence. And then you can see in the upper right corner, the beautiful oligodendroglioma, beautiful in terms of the histology. And here we go. Now that is classic oligodendroglioma on FFPE, formalin-fixed paraffin embedded tissue, perinuclear halos, so-called. It's actually hydropic swelling, cleared cytoplasm, etc. Classic case of oligodendroglioma. This histology predicts with about 85 to 90% accuracy IDH mutation 1p19q co-deletion. All right, and there are other. There's always going to be a 5% or so exception. Now, the question Chat question, where do calcifications come from? It definitely is a disturbance of the micromilieu that is not specific for oligodendroglioma. Most of the time, they begin in the vessels. It's the blood vessels as micronodular mineralization, and then they grow from that. And you can see it. You can see that process develop in some specimens, and we'll present that at some point. Okay, let's see. Next, I think it's very important that we always present a spectrum, not just one thing. So if you look at patient number 1 up here in the upper left, it's the CT scan, brain windowed at the top, and then MR gradient echo, T2 gradient echo at the bottom. It's where you can see as the so-called blooming susceptibility artifact of the case. It really visualizes nicely with both modalities. All right, and then moving from patient 1 to patient 2, patient 3, patient 4, you can see increasing amount of calcification. And I picked these cases because they show gyriform. It's not always gyriform. It can also be clumps, chunks, etc. Look at patient number 3. Is that magnificent gyriform calcification or what? And you can see the companion susceptibility weighted sequence. And finally, patient number 4 is showing both gyriform or curvilinear calcification as well as this chunky stuff. All right, and then you can see the companion pattern at the bottom. I always like to present a range because you never know what you're going to get. Now, the case that I chose for you today as the challenge, remember, every case that I show in this conference is a current patient. I'm not digging back into archive files, et cetera, et cetera. Now, I will say this. It's a current patient. Now, sometimes we may be 20 years down the road in the process, and the patient is coming into clinic, it comes across my desk, this, that, or the other thing, and I will go back to the original scans 20 years ago and show those, but this is all current stuff. Now, if you look at patient number 1, that is the minimal, just like similar to the case that I showed you, that is like about the minimal amount of calcification, but it's very real, and it's not always curvilinear or gyriform, but when it is, it is strongly suggestive of oligodendroglioma. It just means put that at the top of your differential diagnosis. Okay, can diffuse astrocytomas show calcification? Absolutely they can. Yes, it's not pathognomonic, but it's suggestive. It just says move this to the top of your list. Okay, is that good? And there's the spectrum. Okay, that was a nice CT warm-up. I think we should do a histology warm-up. Everybody up for that? And we're going to do a spin on it today. Instead of a typical FFPE, we're going to do cytology because that's the way it starts in the frozen section room, which is some of the most intense work that we do, and it's time sensitive because the patient is under anesthesia on the table, and the surgeon, the neurosurgeon, is depending on us to give them the accurate diagnosis to manage treatment, right? And that is the highest form of intraoperative consultation, so-called frozen section. All right, so let's start with cytology. Frozen section rule number 1, intraoperative consultation rule number 1, perform a cytologic prep as a complement to the frozen section tissue. And for those of you who have interacted with most neuropathologists, we all do this as a subspecialty. There are multiple ways to get the cells on the slide, and not all techniques work well for every specimen. You have to be flexible. So a touch or imprint, that's literally picking up the tissue with your forceps, touching it. You can touch once. Some people like to touch, and then straight into the alcohol quickly to avoid air dry. Some people love air dry, so I guess you could touch, wave it around, get the air dry going. It all depends on what you're used to seeing. All right, also called an imprint, smear or squash or crush. All right, these are all similar terms. These work well. We're going to look in just a second about what works well for that. A scrape, what is it? Okay, someone's not muted talking. Mute. Alex, get on it. All right, scrape. What is a scrape prep? A scrape prep is where it's going to be dense fibrous tissue, and you take your scalpel, you hold it, if it's tissue's big enough to hold with forceps, scrape, and all that gras-du on the blade, you smear that on the slide straight into the alcohol, and that will pull out any infiltrating carcinoma in dense fibrous connective tissue. Finally, drag prep. Imagine drag prep. Imagine you receive a Petri dish full of 100,000 fragments of necrotic debris. You pick out one of those fragments, you freeze it, it's necrosis, totally nonspecific. Freeze another one, necrosis, another necrosis. How can you maximize sampling of this Petri dish full of necrosis to pick out the 1% of viable metastatic carcinoma cells. Well, here's how you do it. You pick up the first piece, you drag it, use some force, crank down on it on the slide, put it back in the Petri, grab another one, drag, 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 same slide, another one, drag, all right, into the alcohol. You can do 5 or 6 of those and avoid the air dry that fast, avoid the air dry. If there are any viable clusters, you'll pick those out, okay? And this is just a nice little table that I created years ago, actually for a chapter that I did with Ken Aldape way back in the day when Ken Aldape was at MD Anderson, and just showing the different types, technique, touch, smear, scrape, drag. Depends on the tissue consistency. All right, soft and adhesive works really well for a touch. We always do this with pituitary adenoma because we're looking not so much at the cells themselves, but at the biology, which is clonal expansion of a single acinus, that single tumor cell, with loss of the fibrovascular septa partitioning, and so the cells shed profusely. With normal adenohypophysis, with this acinar organization, you do a touch prep of that and you get mostly red blood cells and a very few adenohypophyseal cells. With pituitary adenoma, you get massive shedding. It's the biology. All right, soft smears. It's like a crush and a smear. Some people just do a crush. Literally, you crush and then put that into the alcohol. But a crush and a smear works really well for soft specimens, gliomas, most primary brain tumors, most metastases. This is an optimal way to do it. The scrape, I've already talked about that. Dural, paraspinal metastasis, a lot of connective tissue works well. Drag, we've already talked about that. You also want to sample, sometimes with stereotactic radiosurgery specimens, a drag is optimal. You want to drag the entire piece because oftentimes post stereotactic radiosurgery, there's new enhancement. Question is it radiation necrosis or is it viable tumor? Often in these specimens, what we will see on the permanence will be 95, 98% radiation necrosis, 5%, 2% histologically viable, mitotically active tumor. And that's the way you would sample that in the frozen sections. Drag the entire thing, cut the surface and drag it. All right, now note, very important. I'm speaking to the pathologists here, radiologists, neuroradiologists, be patient. The different cytologic techniques are not mutually exclusive. There is no law, believe it or not even in Texas, that you can only perform one type of preparation. And look, here's the way it works. Let's say you're going to do a squash. And so you have one slide, you put your smallish piece of tissue on that, and then you take a second slide and crush and scrape with it, crush and smear with it. Okay, that second slide I put in the trash, because it's going to have a minimal amount of tissue. The majority of tissue is going to be on the slide. Okay, and you know what I do with the second labeled slide? If the histotechnician has made you 2 labeled slides, with the second one, I'll do a drag or a scrape or a different technique. You do whatever you need to do to get the tissue on the slide. In my personal opinion, that is a better use of 2 labeled slides than having one good slide and then one that's basically trash and it's taking up room, in storage and costing you money and all of that stuff. Okay, and that's what I said. You can perform more than one in the intraoperative situation. All right, also note, the different cytologic stains are also not mutually exclusive. All right, we tend to do an H&E where I trained Duke University under F. Stephen Vogel and Peter Berger. We always did a diff quick, right? Water-based, super fast. We did a diff quick, then we did the H&E on the cytologic. We had two slides, and then the tissue section, on the frozen tissue section would come last. So the diff quick gave us something to, quote, chew on while we're waiting for the H&E of the cytologic prep, and then would come the frozen section. I think that is a marvelous way to do it. And that's one of the reasons why Peter Berger, smart man, and that's why he's been so successful in this business. You can do more than one. If you like pap stain, absolutely do that. Whatever you like, do multiple, all right? You can perform more than one. Okay, so let's start off with the case. So here's going to be the case. It's not a case. This is just this is our histologic warm-up. Okay, this is whole slide imaging in the upper right. You will see the whole slide except for the label, which have the patient identifiers and all that stuff. There are only 2 types of patterns, really. Let's call it 3 types of patterns on a smear. The first pattern is chunks, clusters. And that's going to be because the cells are very cohesive with each other. And that's either due to intercellular junctions, like in a carcinoma, or very long processes that get intertangled, like in a schwannoma or a sarcoma, or those are not mutually exclusive, maybe both. maybe intercellular junctions, desmosomes, and long processes, that is a meningioma, right? The other pattern, the second pattern, we'll say, are single cells. What types of tumors you see single cells? Obviously, lymphoma is going to be one of the biggest. Some oligodendrogliomas will do that. Melanoma would be another example. All right. And the third pattern, I said really third. You know what the third pattern is? Really no cells, or just red blood cells. And that's where you take a fibrous, right, a fibrous little chunk of tissue, put it on the slide, try to squash it, try to smear it. It doesn't smear well. You put both slides in the alcohol, the tissue clump falls off. It's in the bottom of the alcohol, and it's all over, and you see almost nothing. What would be a better approach in that situation? Do a scrape if it's big enough to hold with forceps. If not, you do a high pressure drag, right? Really crank down on it. Okay, here's our case. Bam, diagnosis. Diagnosis, I'm going to wait just a second. I know this is a shock because here we are. I'm going to give you a few minutes to absorb it. It's really a differential. It's always a differential, but it's actually possible to make a specific diagnosis off this smear at this power. I'm going to show you how higher power, all right, for sure, but I just want to give it a chance. Listen, did you know that there is a neuropathologist? I'm seeing, yes, Giselle, all right, Lopez at Duke, nailed it. Good job. Zainab gave a very good differential diagnosis. All right. Did you know that there's a neuropathologist, I think still in practice in Canada, who virtually never does frozen sections? It's always for intraoperative consultation, frozen section would be a total misnomer, because all he does in 99% of cases is a smear or one of the other cytologic techniques, and is very comfortable making virtually all diagnosis on that, and in fact published a book, an atlas of smears, all right, based only on that technique. What does that tell you? That an oncologic neuropathologist, he really wasn't oncologic, he did all types of specimens, all comers, would spend a career doing only cytologic preps and didn't feel the frozens were necessary. It means that the information in the cytologic prep, okay, very good job, you got it. It has tons of useful information, right? And that's why we do it. Okay, let's go to a little bit higher power. How about that? Now, come on. This is beautiful. What do you see? You see three things. There are three observations. Remember, why do we do it? Why do we do a cytologic prep, one of these? We do it to be free of frozen section distortion of nuclei and cytoplasm. No distortion. So we see, there actually is some, there could be, if you cry the smear, if you use too much force, yeah, it'll, okay, I'm not talking about that, but there's no freeze artifact. All right, three critical features. The first critical feature is look at the nuclei, very monomorphic nuclei. And if you study them, they're mostly oval, round to oval, but oval. Second observation, very fibrillary. Very fibrillary. And the first thing you might think is diffuse astrocytoma, fibrillary astrocytoma. Definitely glial with long processes. You might think astrocytoma, diffuse astrocytoma, pilocytic astrocytoma, etc. The third observation, but I would point out that that regularity of the nuclei, that would be a lower grade diffuse astro, and even in lower grade diffuse astro, the nuclei will have more pleomorphism typically than this. This is very monomorphic, very uniform. And of course, the critical third observation are these spherical, imagine 3 dimensions, spherical globules of mucin, myxoid material. So you put those things together, very monotonous, round to ovoid, bland nuclei, fibrillary cytoplasmic processes suggesting glial, and balls of mucin or myxoid, and that is myxopapillary ependymoma. Listen, no one has to tell an oncologic neuropathologist what the imaging of this tumor looked like, right? Or the fact that it was virtually certain to be in the lumbar cistern. Not 100%, 95, 98%. There are rare examples of intraventricular, fourth ventricle, supratentorial myxopapillary ependymoma. And that's just because the morphology looks like myxopapillary ependymoma. Are they myxopapillary? by molecular, et cetera, et cetera? I don't know. There haven't been that many studies. You know, you would think with DNA methylation profiling that we have now, wouldn't it be interesting to subject those weird ones, the rare birds, and I'm sure this is being done and will be being done increasingly to sort them out to see what methylation class they sort with, or if they're independent. All right, but here's my point. Here is my point. Just from looking at this smear, an experienced oncologic surgical pathologist, surgical neuropathologist can reconstruct everything with a high degree of accuracy about this patient, including age. Typically, they're going to, it's a young adult, median age about 20s to 30s, maybe 32, 37. That would be a typical age. Lumbar cistern. What about the imaging? We'll talk about the imaging in a minute. Typically, these present as so-called sausage shape or boxcar, et cetera, but we'll go into that. I really like this. This is just one aspect of the smear. You know what this looks like to me? I know, pathologists are continually looking at patterns and giving names to a pattern, right? So we compare that usually to food or to other objects, et cetera, et cetera, et cetera. To me, this looks like the capsule holding the astronauts blasting off to the right. All right, from the mothership. I mean, isn't it? It's pretty good, isn't it? I think it is. It just struck me that way. There it is. That's a capsule. Astronauts are in there, right? That is magnificent. This is art, and this is the sort of thing that inspires tissue pathologists. And we have to be all kinds of pathologists in this day. We have to be tissue pathologists. We have to be molecular pathologists, and we have to be imaging pathologist. You're going to need all of that. Plus, you're going to need to be a physician and know about the history and treatment, et cetera. Okay, diagnosis. We don't see the histology. Here it is. This is the histology. That's interesting, isn't it? See the monomorphic nuclei? What do you think about those vessels? Those vessels are interesting. Let's look at them up close. Well, they're hyalinized. Okay, what does that mean? Is that something earth-shattering? Does it change our diagnosis? No. This is on the spectrum. They didn't look like this everywhere. I'll show you in a second. Areas of the tumor had hyalinized vessels, just like this. All right, now you might be tempted to think hyalinized vessels, hyalinized stroma. What's the other ependymoma variant, we'll call it, just for a second? It's not really that you might think of. So ependymal appearance tumor with focal areas of dense vascular hyalinization, which can yes, Andrea Gilbert. Yes, sclerosing ependymoma is good. I'm thinking of a tumor that's no longer called, though it's not called ependymoma. What's the other one? Remember the one that has been called, it was debated in the past whether it was ependymoma, but you have areas of sclerosis. No, not coming up. And no fibrillary at all, like an ependymoma. Wall to wall, listen, wall to wall perivascular pseudorosettes. But we don't call them ependymal rosettes because the processes are very thick, stout, about the diameter of the nucleus, going all the way. Yes, Dr. Harb, astroblastoma, you might think about. All right, now this is another area of our tumor. Here you can clearly see, look at the radiating cell processes going to the blood vessels. That is a beautiful perivascular pseudo rosette of ependymoma, screaming ependymoma. Now, this would be traditional ependymoma, garden variety ependymoma, like you might see in the fourth ventricle or in the spinal cord parenchyma, all right, intramedullary, or supratentorially, either in the ventricle or at least half of all ependymoma supratentorial are in the parenchyma, correct? With I think I'm using Dr. Prieto. You got to be careful who you hang with. Dr. Prieto is always saying correct. You'll make a statement correct. And now look, I'm doing it. That just happened today. This is a first. Okay, now let's go out to another area of this same tumor. Here, look at out here to the far left, the margin. Those are the globules. All right, so these are spheres, microcysts full of myxoid material that we saw in the smear. Excuse me, and to the far right, look at the perivascular cuffs. So mucin or myxoid material in myxopapillary ependymoma, two things to remember about it. Number one, the amount of myxoid material varies greatly. This is the spectrum. It varies from virtually none, 0, to comprising 80% of the volume of the tumor. Massive perivascular cuffs, microcysts everywhere. And again, the oncologic neuropathologist must be prepared for the full spectrum. What's going to help you a lot? Well, it's in the lumbar cistern. is question. Is myxopapillary ependymoma the only ependymoma variant that occurs in the lumbar cistern? Answer, as you can guess, no, absolutely not. There are other flavors. We're going to look at that in just a second, okay? All right, now just another beautiful view of the myxoid microcysts, and look at the ones here in the sort of the center of the field. Look at the long perivascular cytoplasmic processes, okay, and even higher power of these beautiful. See, this is a perivascular pseudorosette. It's a perivascular anuclear, nucleus-free zone with the fibrillary processes, except in between the processes, the mucin it dominates the picture and squeezes out the processes so that you don't even notice it. Variably present, okay? Myxopapillary ependymoma. I'm telling you, an experienced oncologic neuropathologist nails this on the smear, even without, quote, cheating, if you will, by looking at the pre-op imaging, which also will be highly suggestive, but myxopapillary number 1 on your differential diagnosis. It's almost too easy. You know, really, I'm not sure we should be compensated for making this diagnosis, right? Third grader could do it. Okay, here we go. This leads us, nice segue to the macroscopic morphology or gross anatomy, if you will, the photo of the week. Do you know what it's going to be? That's the tumor we just looked at. This is the intact en bloc resection of that myxopapillary ependymoma. Is it not magnificent? Now, this is the way they always should be resected when possible. Unfortunately, many times it's already out of the bag at clinical presentation, meaning there are micro CSF metastases throughout the roots of the cauda equina and up against the arachnoid of the lumbar cistern. Even if the neurosurgeon cannot see the micrometastases with the loops, the magnification of the loops, they can still be there, which is why all these patients need to be radiated. More about that in just a second. So here it is. Here's the whole picture. Do you like that? Look in the upper right here. All right, there's real life, the specimen here. You can see centimeters. That is just about a centimeter. All right, more or less centimeter by half centimeter all directions. And then the histology and the FFPE on the bottom right. Let me ask you a quick question. This looks like it came out of a textbook, doesn't it? But it didn't. I put this together. How long did it take me to construct this? Well, I'm pretty good at it, so it didn't take me that long, but it took me some time. How much work do I put into this conference? You think it's easy? It's not easy. But you know why I do it? I do it for collaboration. I do it for teaching. I do it to try to raise the bar of excellence in terms of how we present. All right, like that? MR imaging, IPR. All right, let's do that. IPR means instant pattern recognition. Now, as we talked about before, I'm going to qualify that. Whether something, an image, whether it's radiologic or histologic or genomic pattern of mutations or alterations, depends on your level of training. If you're a medical student versus a first-year intern pathology resident, versus the oncologic neuroradiology fellow, it varies. I'm just going to call it IPR. All right, here we go. Okay, then the first thing, I'm just asking you, what it is. Now, let me put it this way. I call it IPR. What I should be saying, it's really differential diagnosis. Maybe I should have changed that, but there's a few things. So let's change it, if we will. Allow me to change this. I want the differential diagnosis. Now, the first thing, you're going to have to spot the lesion. Now, all of the neuroradiologists that are tuned in and neuroradiology fellows, they're back to surfing the net and checking their emails at this point. It's like, get on with it, would you? All right, has everyone spotted the lesion? You see where it is? Now, I did not give you the most obvious scan. Oh, I'm going to make it easy in just a second, right? So if you are having, anyone listening to this conference, if you're having or had a little bit of difficulty seeing the lesion, that is the point. Because in life, and it doesn't matter if it's radiology or pathology, there are going to be difficult cases where you don't have perfect images, perfect tissue, perfect pathology. For the pathologist, you're going to have tiny bits of cauterized debris. And sometimes there's nothing you can do with it. Other times you have to try. And if you can pick up the clues and be thorough and be detail oriented, you might save the patient a second operation. And remember, we must never complain about the quality of the images from the outside, about the quality of the path, et cetera, et cetera. The first thing is the patient. The first thing is the patient. Let me tell you a quick anecdote. I think it's worthwhile. Milam Levins. He is the former head of neurosurgery at MD Anderson Cancer Center before Dr. Sawaya came along and built the program massively into what it is today. Dr. Levens was chief of a small shop back in the day. Neurosurgery was a section, part of the Department of Surgery. It was once said about Dr. Levens, you know, he never was about research. He was always all about the patient. Now, I'm not sure if that was meant to be a left-handed compliment, like as in not a compliment or a compliment. I tell you, it's a high compliment because he always was all about the patient. And we need in academic medicine, at MD Anderson Cancer Center, Baylor College of Medicine, Duke, wherever you are, we need all kinds of people in our department, whether it's neuroradiology, pathology, et cetera. We need all kinds of people. We need researchers, Jason Hughes, pushing the field forward. All right, Leo Ballister, pushing the field forward in the laboratory. We also need Dr. Levens, people like Dr. Levens, people like me. It's all about the patient. The patients tomorrow need the research, need translational research. The patients today need excellence in surgery. They need Dr. Sujit Prabhu. Okay, that's just a little lecture. All right, you like this one? Is this better? Should I have started with this one? What do you think about that? You can see it down there, lumbar cistern. All right, there, we won't belabor it. Okay, now you go up a little bit higher. So these are higher magnified views, and I think, yeah, okay. All right, let's just keep going. Here you can see the lesion in, this is coronal, and you can see the lesion right here. Now there's a reason why this is actually, so what we have is a circumscribed contrast enhancing mass in the lumbar cistern. Now, if you haven't figured it out, this is the myxopapillary ependymoma that we just looked at. I was trying to squeeze two things out of one case, all right? That's not uncommon. But I have some more points to be made about this. Now, this is actually my favorite image. Do you know why? Because I think I've labeled this for you. There's a lesion for anyone who has a spot, if you're not familiar with it. This is my favorite image. Oh, and there it is. Yes, shocker. All right. Oh, yeah. Okay, I just couldn't resist. Wow, I put this in twice. Isn't that cool? You know, one of the things that's interesting about it, it's a myxopapillary ependymoma, and guess what? It's not a sausage or a boxcar. It's almost a spear. It's just a little bit elongated. You know what? They can be perfectly spherical. The reason why they tend to be sausage or boxcar shaped and really large is because in most patients, it takes that long with the capacious nature of the lumbar cistern for the tumor to get big enough to interfere with the cauda equina roots to produce symptoms that are severe enough, serious enough that the patient seeks clinical attention. So it's relatively rare for a tiny one like this, free floating, or not free floating, but attached to the filum or to a nerve root to get big enough. But occasionally we do see them. This is again relates to spectrum, and you have to be familiar with the full spectrum. All right, but listen, this is the reason why I love this scan. What are we looking at the arrows? Anybody have an idea on the arrows? Yeah, I'm pretty sure what this is. All right, if you know. All right, here we go. I know it's a long thing to type. All right, let's look at the anatomy. There's the tapering conus medullaris. Look, is at the top. All right, Sergio Pinovieto, filum. Good job, Sergio. All right, so look, here's going to be lumbar cord, sacral cord, tapering conus medullaris. Here's the filum. Here's the mass. Here's the rest of the filum. Now look, what is interesting about this? And this looks like a perfect coronal plane straight through, really rare to get this long of a segment of filum. All right, that's why I love it so much. What is it telling you? Is this mass dead centered in the filum? No, it's eccentric, correct? This is my crude line showing the plane from lumbosacral cord, conus, filum, all the way through. The tumor is eccentric to the left. Does that make sense? For myxopapillary ependymoma, would you rather make it a schwannoma because it's eccentric? Maybe it's just coming for a root, or maybe it is coming from the filum. There are nerve fascicles in the filum itself. No, it makes perfect sense. Now, some will appear to be centered in the filum, sure, but it makes perfect sense. Listen, it makes perfect sense that the myxopapillary ependymoma, in its smallest form like this, would be eccentric on the side of the filum. Why? Now you're going to say, no, wait a minute. I thought myxopapillary ependymoma, that's a type of ependymoma, correct? And there it is. I'm channeling Dr. Prieto again. So I thought it comes from the remnants of central canal. And the central canal is in the center of the cord. And so therefore, shouldn't it be an equal expansion all around? And the answer to the question is yes. Ependymomas in the spinal cord proper, that is at the conus level and above, the intramedullary ependymomas are in the center of the cord where the central canal is. Yes, in fact, that's one of the ways on cross-section that we tell by imaging, or that we favor ependymoma, because in the middle, it's in the, or no, if you in the middle, it may obscure the whole thing, but if you go to the top and bottom, that is the most cranial or rostral and the most caudal or inferior cuts of an intramedullary spinal cord ependymoma, where it's smaller, tapering, you'll see that it's in the center, and that strongly favors ependymoma over the other common tumor, diffuse astrocytoma. Diffuse astrocytomas originate from astrocytes in the funiculi, lateral, and the biggest funiculi are the lateral funiculi, so they're typically lateral in the cord, correct? We've been over that before, and we'll do it again at some point. Okay, well listen, then why does it make sense that myxopapillary ependymoma would differ, because it's coming from the same cells, the ependymal remnants, no question about that. Why is it eccentric? And the answer, if you are logical, think about Sherlock Holmes. What was the statement? Whenever you have eliminated the most likely, the probable, whatever is left, however improbable, must be the answer. Well, it must be that the ependymal cells, the remnant, are not in the center of the filum, and they're not. They're not. Now, you know, you wouldn't know that unless you have actually seen a human filum terminale in cross-section, and then you would know they're actually at the surface. That's because the inferior neuropore opens, all right, opens to the surface at the end of the forming canal tube. Therefore, the ependymal cells are at the surface. You see how beautiful that is? When you understand it, you will never forget it. But I think we need to see it, all right? Yes, eccentric. It is eccentric. That is exactly right. Now, what is the best place to see a cross-section of the human filum terminale? Well, of course, the most clinically relevant resource for human histology, well, I don't know, I always go to Fuller and Ballister. Yes, Sergio, histology for the pathologist. I put 2020. I'm not sure, it may actually be 2019. It came out in 2019, but you know, 2020 sounds really current. So I'm gonna keep calling it 2020. I don't know, I may even switch it to 2021 next year. All right, it's a good book. If you've never had the volume at all, you may want to consider it, or just the CNS chapter, because it's really the one worth reading. All right. I didn't say that. What happens in this conference stays in the conference. All right, here we go. Back in time, Histology Pathologist, first edition, 1992. This is Peter Berger to the left. This is me to the right. Look at the calendar on the wall. It's 1990. That's when we submitted the manuscript. This is the manuscript being FedEx to the publisher. We've just finished it. This is Ian Sook, Medieval Studies Classical undergraduate at Duke University, worked part-time as secretary. He hand-typed on a typewriter the manuscript, all right? I think I have to give full disclosure. I own half of FedEx. All right, please use FedEx. I'm just kidding. All right, here we go. This is Peter Berger, my mentor in neuropathology. I think it's important to acknowledge our mentors, and that's why I do it as often as we can. We can't pay him back. There's no way I can pay Dr. Berger back for everything that he has done for me, but what I can do is I can pay it forward, and I can acknowledge his contribution. I want to say in the same breath that my mentor in neuroradiology is the late magnificent Dr. Norman Leeds, who we lost recently, and we should always acknowledge. Okay, now Dr. Berger have a mentor? Yes, Dr. Berger's mentor was the wonderful F. Stephen Vogel. Dr. Vogel was also my mentor. I was his last trainee at Duke before he retired and moved to the USCAP. So he was at USCAP president for some time, and then he went to the IAP, was the head of that organization. Absolutely. All right, and this is when he retired, and so here is the master, Dr. Vogel, being handed the plaque of the trainees by Dr. Berger in Duke, and this is what that plaque is. I really like this, not just because I'm on there. Dr. Vogel trained 20 academic neuropathologists, 20 academic neuropathologists, and you'll recognize some of the names here. At one point, I'll show them as we go through their accomplishments. Anyway, all right, back to it. Here we go. It's eccentric. All right. So let's go to the chapter. All right, Fuller and Ballister. Here's the, look at the spinal cord on the left. Beautiful. I believe this is Dr. Ballister's photo. And you can see spread out on this black screen. This is first-class photography. Look at the conus and the filum down here in the middle. All right, and look at the right. All right, you can see that the filum, human filum, is 95% collagen. The blood vessels, these are peripheral nerve fascicles. There's one right here, and there's another small one next to the vessel down here. And then look over here to the far right. That is the, quote, central canal remnant in the filum. There's the helpful arrow. Here it is writ large. This is from the book. Look, the surface is right here, up to here. This is the surface. Those cells are right there. Don't you think that they break through this thin layer of pia super fast, super easy? Yes, that's why frequently there's dissemination. Sometimes it's microscopic, can't be seen by the neurosurgeon again. Excuse me, that's why we radiate. All right, here's the legend. Filum terminale. Filum terminale term spinal cord extends downward from the conus, surrounded by nerve roots called the quad. As seen in cross-section, filum composed dense collagen, blood vessels, small peripheral nerve fascicles, and of clinical importance, often eccentrically, there it is, eccentrically located ependymal remnant central canal. The latter structure shown at high magnification is the origin of myxopapillary ependymoma. This is a bonus. This is value added, a remnant of the embryonic terminal ventricle of Krauss, ventriculus terminalis, which consists of focal dilation of the central canal in the region of the junction of the conus medullaris to the filum. Now, this is at the conus. This is not down in the filum, right? It's up in the conus where it's still central, and there it is, maybe encountered in sections from this vicinity. Isn't that cool? So for those of you who have never seen a human, the histology of human filum terminale, or a real terminal of Krauss, now you have. All right, and that's the sort of thing we're going to do in this conference. Hopefully, over the course of the year, we will show you things that you will not see anywhere else. Thank you, Dr. Harb. Dr. Harb says, very cool, and truly it is. All right, so we're talking about myxopapillary ependymoma. We're talking about ependymomas. Now we have to go to the CNS5, the WHO 2020, which will be out, should be out in a few months. It will be out in 2020. Let's look at ependymoma classification. Things have changed over WHO 2016, all right? All right, see impact now, update 7, advancing the molecular classification of ependymal tumors. All right, and this is hot off the press. Recommended ependymal tumors. All right, let's take them one by one. You can see tumor type on the left, and here's WHO grade on the right. Now, the first thing you're going to notice, look at the first category are supratentorial. So we're going to divide them by anatomic compartment first, then by molecular signature. Look at these first two guys. All right, C11orf95 fusion positive. That's the REL-A. C11orf95 is more constant as a partner than REL-A. That's why we changed it from REL-A fusion positive to a C11orf95. That ORF, that's open reading frame. So we don't really know much about it. All right, we're learning more about it. All right, and YAP1 fusion positive. Notice the grade. Notice the absence of the grade. The only thing that has a grade is supratentorial ependymoma NOS. The NOS is not here, but that's what it is. Since it's probably going to constitute the majority, at least early on, as people acquire more capability of determining these two guys, NOS still has to be histologically graded, right, by the standard things: mitotic activity, vascular proliferation, maybe necrosis. It probably does not matter, but we're still going to do it, and the primary care physicians, the cutting edge people who have to treat the patients, are going to want it. Now, notice with respect to that, go to the bottom. Footnote: sufficient data are currently unavailable for a WHO grade to be assigned to molecularly defined ependymomas. Now, I think we know it is generally accepted that the REL-A fusion positive or C11orf95 fusion positive have a relatively worse prognosis compared to YAP1 and as well to NOS. However, it's not definitive yet. It's not 100%, hence the footnote. And for some of the others, there's still a concern. Everybody got that? This is good stuff. What this means is if you are able to determine molecular signature, you do not have to use histologic grading anymore for these, because that's what it says. All right, it won't be there. It's not the WHO. All right, let's go to the posterior fossa, next anatomic compartment. Posterior fossa ependymoma are group PFA. That's pediatric. All right, and then group PFB. That's posterior fossa. It's pediatric type. Pediatric type, posterior fossa A. All right, PFB. All right, ependymoma, posterior fossa ependymoma. If you don't have information. All right, then moving on, spinal ependymoma, MIC-N amplified. Bad actor predicts a worse prognosis to Gordon-Brody or non-MIC-N amplified, which we still have to grade. All right, you like that? Okay, here we go. Two more. Myxopapillary ependymoma. Now here's the big change. Myxopapillary ependymoma in every iteration of the WHO classification, including the WHO 2016, which we are still kind of halfway under, not so much because of the C Impact Now updates. We can reference those as the C Impact Now update, 3, 6, 7 criteria. You can use that in your reports now because that's what's coming. Myxopapillary ependymoma, MPE, has been grade 1. Notice this is grade 2. It is going to grade 2. Why? You already know why. Why is it moving to a 2? Because the central canal remnant in the filum terminale, the site of origin of MPE, is superficial, not central. Therefore, a large number of these tumors are already out of the box, already disseminated, and they are so low grade, they do not respond well to radiation or alkylating agents or anything else. So it is a long course. That's why they were called ones, 10, 15, 20 years of increasing morbidity. So that was considered a favorable thing, but maybe not so much. We have appropriately changed that to grade 2. 2 reasons for the problem. Number 1 is the central canal is superficial. The other reason is, as I mentioned, it's very rare to get the cases like I'm showing you today, where the tumor is so small that it's actually a sphere rather than this very large, long sausage or boxcar. And obviously, there's a much higher incidence of dissemination for the larger tumors than the small ones, right? Okay, so those are the 2 reasons. And finally, we need to be inclusive. Subependymoma, that is the fourth subtype. Now, subependymoma is in all compartments: supratentorial, lateral ventricle, and fourth ventricle, and also cord. All right, here's the whole table. Let me give you one second to gestalt it. Take it in, okay? It's important we go over this. All right, what is this? This is your next unknown. It's an axial T2 section, all right? Looks like it's fat suppressed, all right? And what is the tumor that we are looking at? What is the tumor? Saying that hard. Subependymoma. Good job. Yes. Okay, I'll tell you. I like what you said. That was astrocytoma. Now listen, I'm liking that. I like astrocytoma. You know why? Because it's lateral. Because it's lateral. All right. And because it's lateral, if you think funiculus, you would think astrocytoma, but it's a little too sharp. It's a little too sharply circumscribed on the edges to be astrocytoma. It's more distinct, right? And here's the point. This is a subependymoma of the cord. This is subependymoma. Now, the main point I want to make sure is that everyone listening to this conference knows that subependymomas are not only in the lateral ventricle and the fourth ventricle, they are also intramedullary in the spinal cord. Now, it is the 3rd most common site, much rarer than the others, but we have cases at MD Anderson. Every tertiary hospital has them, and you know what? Let's say you say, well, I'm going into private practice at the community hospital. That's where the cases come from, most of them, because the collective number of community hospitals far outnumbers the number of academic tertiary care centers. You're going to see them. So it's lateral because the subependymal plate is lateral, right? Makes sense. All right, here's just comparing on axial section, comparing T1 post, see the ependymoma. You can see there's a rib, very circumscribed. Look at the ependymoma and subependymoma. See, they're both sharply circumscribed. See how the ependymoma is surrounded by a mantle of spinal cord? Yeah, right in the center, right where the central canal is. Subependymomas come from the subependymal plate, which is lateral to the central canal, so they're going to grow eccentrically or lateral within the cord. All right, now let's deal. This is the last thing I wanted to deal with. Then we're going to move on. Myxopapillary ependymoma, spectrum of imaging morphology. All right, now this is typically what you think of when you think of imaging of myxopapillary ependymoma is sausage or boxcar. The boxcar, those are the containers, like on cargo ships, containers, and then they're loaded onto 18 wheelers, the semi-tractor trucks. And so they're, bar, it's a big, long rectangle. You see how the ends often are flattened? See how flat this is, and maybe the upper end here. Look at this one on the far right. See how flat? That's why boxcar, like container, is what it is. All right, this is what we typically think of. All right, this is our case. That is not a sausage. It is not a boxcar. It's basically a sphere. right? Again, spectrum. This is what we have to know as pathologists and as oncologic neuroradiologists. We have to know spectrum, all right? So, and so look at this. This was the original figure. I chopped off the one on the right and the one on the left, so it didn't look artificial. This is the actual composite figure that I showed maybe once or twice in this conference. Look at the far right example. This is not the present case. This is a different example. You see, it's basically spherical, right, in that location, you know, just below the filum, like so. This is another sphere. So it's not like it's the only example. All right, and there it is. That's what I'm talking about. Okay, here is the other case. All right, I mean our case today. All right, and so this was the old figure. What do you think the new figure is going to look like? Here's the new figure, going from smallest to largest, and that is how it works. Now this is 9 different patients. I really need 10, so I'm just waiting for the 10th. We'll probably it'll be within 2 months. I would guess. Okay, this is the extreme, and here's the point. Huge point. If you're going to be working with brain tumor patients, these are the extremes of what needs to be in your brain for the imaging morphology of myxopapillary ependymoma. It goes all the way from a small sphere to a very large, completely filling the lumbar cistern sausage or boxcar. Okay? All right, question. This is the last little bit of this. Imagine that you did, this is our case. Imagine that you didn't know it was myxopapillary ependymoma, right? What is your differential diagnosis? Let me rephrase that if I could. What is the differential diagnosis for a round to oval, let's call it round to oval, circumscribed, contrasting enhancing mass, non-dura-based in the lumbar cistern? Dr. Gilbert, neuropathologist, UT San Antonio, says schwannoma. Absolutely. What else? Yes, Octavio, schwannoma. What else? It can't be just schwannoma. That's not a differential diagnosis. All right. Oh, yes. Sanjay said paraganglioma. Andrea Gilbert, clear cell meningioma. Hey, Andrea, Dr. Gilbert, you're scarfing up all the best diagnoses. Okay, Sergio, yes, metastasis. Look, if you don't put metastasis on this list, you're a goner. All right, here we go. Schwannoma, fantastic. Yes, ependymoma, myxopapillary ependymoma, tannicytic ependymoma, pigmented ependymoma. Pigmented ependymoma. Yeah, they're extremely rare. What does it mean? It means nothing. It means that ependymomas, guess what? Come from neuroectoderm. Any neuroectodermal tumor can have melanin pigment, and there are some ependymomas that have pigment. That's all there is. It's mentioned in a long little laundry list in the WHO as some ependymomas can show, right? That's why I put it in here. And other can be just garden variety ependymoma. I just want you to know, right? That is the spectrum. All right, I totally messed that up. Okay, you see I forgot to delete a slide. That's okay. Meningioma, what type? All right, Dr. Gilbert has already told us. Clear cell sclerosing, because that's what they typically look like. They have all that collagen, not dural-based. They are never dural-based. Now, do dura-based meningiomas arise in the lumbar cistern? Yes, they're the most common. The most common meningioma in the lumbar cistern is a garden variety dural-based meningioma. Yes. But clear cell sclerosing meningiomas are not dura-based. They arise from the arachnoid, just like the others, in the arachnoid trabeculae, which crisscross the lumbar cistern and surround the cauda equina roots. And they are not dura-based. And once you know that they are an exception to the rule, and you can have non-dural-based meningiomas, in other places, they've been reported, in the cisterns all over infratentorial, supratentorial. But this is the one location where this subtype is relatively common. Got it? Okay, paraganglioma of the filum terminale, never forget it. What does it look like histologically? You know what it looks like histologically? It looks like conventional ependymoma because they're perivascular pseudorosettes. Now, they are the neuroendocrine type of perivascular pseudorosettes, and if you are a general surgical pathologist or oncologic general surgical pathologist, you may pick up on the neuroendocrine nuclei, and that would be a clue to you. Good job. That's why it's good to know general pathology. For the rest, other than that, they do have a distinctive look. What do you do? How do you sort it out for sure? Easy breezy, synaptophysin, and GFAP or S100. All right, there may be in some examples sustentacular cells, S100 positive. The vast majority of my experience do not have those. Wall-to-wall synaptophysin positive, which is not a characteristic of ependymoma. Easy breezy. You just have to know about it. Maybe 10%. If you serially section them, probably up to 50% of paragangliomas will actually have neuronal metaplasia. It's always a treat when you're looking at your tissue sections of a paraganglioma filum, which is rare already, and you see ganglion cells, but that fits into it. All right, and then metastasis is always included. Okay, you know what I'm gonna do? I'm gonna call those the big five. All right, the big five. This is a differential diagnosis. Those are the big five. Okay, imaging IPR number 2. As you can tell, this may be a little bit longer conference. I don't care. It's Friday. It's the weekend, right? Where else would you rather be? Seriously, where else would you rather be? So I'm going to finish this conference. Okay, IPR number 2. Now I'm going to call this the pre-K level. Now I have shown kindergarten level IPRs because I want everyone to be a winner. I want everyone to get a trophy from this conference. I really do, you know, a blue ribbon, a big medal. So I decided to include a pre-kindergarten level. Now, for those of you who may have kids, small kids, pre-K is no joke. We're not messing around here. I mean, they're getting into it, right? Math, all these games, all these programs, all the whatever. I think I played with sand when I was lucky. There was mud, that sort of thing, maybe some straw. All right, pre-K level. It's pre-K level for the neuroradiologist and the neuroradiology fellow. Let us see if it's pre-K level for any of the neuropathologists. Sanjay Singh, all right, the great Don of neuroradiology at the Texas Medical Center, nailed it. I'm not going to tell you what Dr. Singh said. So thank you for confirming that. Octavia Ariola, yes, you nailed it as well. All right, now here's the point. The reason why I did this is just to show you that Dr. Sanjay Singh says he's actually pre-K level, which is not the truth at all, and he's modest, all right, which is admirable. Listen, the reason why I call this pre-K and showed it like this is to show everyone in the conference that there are people out there like neuroradiologists and neuroradiology fellows that can nail these things. They just gave a histologic diagnosis from the imaging. Why, as a pathologist, would you not to already want to know the diagnosis before you're called up to frozen, et cetera? Now you can say, well, like you could say the neuroradiologist will tell me what the diagnosis is. The surgeon will tell me, oh, come on. That's not the way to be a physician, and you'll never be treated like a physician with that attitude. Plus, listen, oftentimes the scans coming from the outside have never been read or have been read where they were, but it may not have been by board certified neuroradiologists. And you may not be able to find the report, you know, in a 200-page PDF in Epic or whatever your medical record is, right? You need to be able to do this yourself. Now, question, why is this pre-K and not K or 101? It's because, if I'm to be frank, if you look at the T2 on the left and well, here, let me just advance it. Look at the T2 on the left and the T1. Do you see the internal structure? There's stuff there, all right? It's a little less obvious on the T1 post. The best examples, this would be, the T2 would be homogeneous, perfect water, just like in the ventricles. And on the T1, it would be perfectly black, just like in the ventricles, all right? Sorry, yeah, okay, I have mislabeled, sorry, moving on. I've mislabeled T1. Hey, it happens. You try putting one of these conferences together. Okay, Doc, thank you, Dr. Harb. I did not just once. Try putting one of these conferences together virtually every week. But by the way, I think I'm on service. I am on service Wednesday, Thursday, and Friday next week. And I really can't do the conference on service, which is no other neuropathologist in the institution because of COVID, so no one can cover. And I get called the frozen section. So when I'm on service, there will not be a conference. Your one and only indication that there's a conference is that Monica Gilliam, you know, our wonderful program coordinator, we'll send out the invitation, all right? And we may go to Zoom, et cetera, when we come back on the 21st, all right? But after the next 2 weeks, after next week, I'll be on. All right, here's the point. And here you can see the restricted diffusion on the bottom, all right, with the DWI and the ADC map confirming it right here. See how it goes dark? Yeah, that's why this was a pre-K, the internal structure. All right, so let me just summarize here. Oh, the histology. Of course, I'm going to show the histology. Hey, you know what my defense is on that mislabel? I bet. How about this? Can I say that they were outside studies and they were mislabeled by the outside radiologist, and that's why I called it. Okay, you know what? That is a pathetic excuse which doesn't fly. And for our oncologic surgical pathology fellows, when we get into the unknown case conferences and you're presenting your conference and you're showing the PowerPoint and you have borrowed some slides from the attending that's your sponsor, advisor, we'll call it advisor for it, and there are typographical errors, there's stuff where the font's bad, all of this stuff, you are personally responsible for the accuracy of, yes, your mentor slides in terms of things like that, spelling errors, typographical errors. Here's the rule. When you present, it's your bag. When you issue a report, it's your bag, whether it's a radiology report or a pathology report, okay? All right, now I'm actually happy that I mislabeled that, because you know what? You know why I'm happy about it? No, Octavio, it's good. Because you have to be able to make mistakes, make them publicly, get embarrassed, get ashamed publicly. Oh, I'm thinking all the things I'm going to do to Octavio. Revenge is a dish best served cold, right? That's Klingon proverb. Okay, yeah, exactly. I'm just kidding. You have to fail publicly, because then you don't forget. You bring in the hippocampus. You bring in emotion. I'll be frank with you. I'm not feeling that much emotion. I'm kind of like Larry Ginsburg, Dr. Ginsburg. Don't really feel emotion. All right, so here's the anucleate squames. All right, you see all this stuff. This could still be a dermoid, but in fact, there are no skin adnexi, and the imaging was just classic. Here are the squames on FOSS. Look, on the left, they are on edge. These are flat, anucleate, no nucleus squames. And here, that's also a beautiful picture, a beautiful image, isn't it? It's almost like stained glass. All right, we have beauty. We have beauty in pathology. All right, yeah, epidermoid cyst, absolutely. All right, here's the bottom line. Epidermoid cyst follow CSF signal on T1 and T2, mimicking arachnoid cyst, but they have variably conspicuous internal structure. This case that I gave today was very easy because of the internal structure. Sometimes it's very difficult, despite the best windowing, to pick it up. Those are the cool cases. But listen, but even if, let's say you have T1, T2, and you think, oh, it's an arachnoid cyst, right? Which is very reasonable. You should never miss the diagnosis. Why? Because there is one sequence in which water, ventricular water, arachnoid cyst water, other cyst water diverges dramatically from epidermoid cyst, and that is the DWI, restricts diffusion. Yes, that separates them. Isn't that awesome? And it makes sense. You know, water, there's no restriction. Water molecules go where they want water. Okay, I just want everybody to know that. We've talked about it many times at the conference before. We will have it again. I'm sure I will show you a case. Maybe I will up the stakes. I do have a spectrum of epidermoid cysts. All right, the T2 imaging challenge case of the week. I decided to get granular this year. We're talking about the 2020, 22, 21 academic year. I'm going to get a little more granular with the challenges. So this is not just an MR, this is not just an imaging challenge or an MR imaging challenge. This is a T2 challenge. All right, you ready? T2 challenge. This is your T2 image of the week. And here we go. What's your diagnosis? Okay, I'm gonna give it just a second or two here. See anybody wants to chime in. You can. I'll accept a differential. Okay, Dr. Gilbert, I like it. Arachnoid cyst, very reasonable for that. Okay, Dr. Susanna Caillet, porencephalic cyst, very good. Dr. Harb, diffuse glioma, very good. These are excellent. All of these are incorrect, wrong diagnoses. For example, it cannot be. Look, it cannot be an arachnoid cyst, because look, if you see the cortical ribbon, can you see down here, see my arrow? Look at the cortical ribbon like so. See how there's no cortical ribbon here? You can see the vasogenic edema in the white matter. See see how there's, if this were an arachnoid cyst, you should be able to see the compressed cortical ribbon going all the way around. Okay, but it's great. It's very reasonable. Okay, what is this? All right, Dr. Gilbert, porencephaly. Okay, that's the second time that misdiagnosis has come up. Let me tell you something. Okay, Dr. Sanjay Singh could not stand it and gave the correct diagnosis. All right, this is really a good one. Okay, I'm going to, before I tell you what Dr. Singh said, I'll give you one hint. We see it, if not every day, we see it every other day at MD Anderson Cancer Center. Every other day. We see porencephalic cysts every other day. I know you didn't have that information. Let me give an easier one. Yes, Dr. Caillet. How about this? Do you like the coronal better? You like the coronal? How does this help? Why is this actually better than the other one? Because the other one didn't have the craniotomy. See the craniotomy up here? I'm sorry, I'm just enjoying this too much. This is lobectomy. So, and this is the case this week. This is a very nice example of a right frontal lobectomy, which is done for cancer, for diffuse gliomas. All right, I believe this was oligodendroglioma. Do you like that? Was it mean? Was it mean to just show you one? I know if you have the whole, I mean, come on. If you have the op note, and I mean, if you're looking at the specimen on the cutting in board, then you know. But look, the point, here's the point. The point of taking challenges like this is eye for detail, right? Now, the most common location for arachnoid cyst is going to be temporal pole, right? And this is frontal, not temporal. It doesn't mean they can't happen here. They absolutely do happen. They happen anywhere there's subarachnoid space. They've been reported anywhere there's subarachnoid space. But if you think in terms of statistics, it's not the most likely location, especially for a monster like this, and to be missing the cortical ribbon. That's really the eye for detail. And see, I tried to pick it where all you have sutures and you don't see the craniotomy here. Wasn't that clever? It was devilish, wasn't it? But as I've said, but it was not unfair. And the reason why it was not unfair, as I've said many times in this conference before, is that however mean or devious that I am with these challenges, they're never unfair, because cancer and disease will be more unfair to you than you could possibly imagine in the real world. And if you don't believe it, spend 30 years in the field and you will experience it. It is coming. And that's why you have to be precise, have an eye for detail, just like Sherlock Holmes, Nancy Drew. Consider all of the possibilities. Could always have a differential diagnosis, and do not fall in love with your diagnosis. Yes, Dr. Gilbert, it's elementary. Okay, what was the genotype of the resected tumor? Okay. Okay, what was the genotype? I've already messed it up. Okay, the genotype, I've already told you it's an oligodendroglioma. Why? I messed up my own question. What was I going for here? What I was going for is frontal lobe. Now, of course, you didn't know it was a diffuse glioma. I agree, but I'm asking for a genotype. So you'd be thinking it means it's possible to generate a hypothesis about the genotype. We do perform lobectomies for diffuse gliomas when they are in non-eloquent cortex, and this is frontal lobe. And here's what I wanted you to know. Long story short, IDH mutant. Listen, IDH mutant diffuse glioma, astro and oligo disease, is overrepresented in the frontal lobe. It is the most common location, the single most common location for IDH mutant. Now, do IDH mutant oligos astros occur in temporal lobe? Yes. Parietal lobe? Yes. Overlap? Yes. But it's overrepresented in the frontal. It's just one more piece of data. Okay, and that's why. All right, IDH mutant frontal lobe. All right, let's do, you want to do a genomic alteration IPR? Yeah, I don't think anybody's even close to being warmed up for the case. Dr. Gilbert says yes. Therefore, we will do it because Dr. Gilbert said so. Everybody ready? Ready? Here we go. Genomic alteration, IPR. It's one image, and I want you to give me the alteration. Just give me the whole diagnosis. I'm waiting. I'm going to wait until someone gives it to me. Okay, I tell you, perfect. We have one correct answer. Anything? You could just put in why just. Yes, Dr. Zainab Harb, Bay State, absolutely. Good job, good job. Okay, that's enough pain and suffering. T2 flare, T1 contrast, non-enhancing tumor. This is classic T2 flare mismatch sign. All right, look at the T2, you can see the soul side, look at homogeneously. T2 hyperintense, look at the T2 flare. You have a thin hyperintense rim, and also you can see where the sulci are. And then all of this hyperintensity on the T2 is suppressed. It's dramatically suppressed. This is an easy case. Oftentimes this hyperintense rim is really thick, or maybe most of it is hyperintense, but you have this area. Imagine if it's only the area that I'm circling, and you go over here in the T2. Yeah, it is hot here. It is cold here. It is suppressed. That's what we see in some. And still, it is highly predictive. Here are the two caveats to it. Listen, two caveats to employing the T2 flare mismatch side. Number one, adult, not pediatric. There are many pediatric tumors that show T2 flare mismatch sign, which do not have diffuse astrocytomas IDH mutant. All right. And number two, it has to be a diffuse glioma, obviously, and you're going to pick that up. Look at the T2. Go over to the T2. And what you can see, look at this particular area right here, the cortex. You have effacement or blurring of the gray-white. Go to the contralateral hemisphere. See how sharp the distinction is between the white matter and the cortical ribbon? That's the gray-white junction, very distinct. Look at it right here. No, it's total. That's because vasogenic edema, imagine vasogenic edema would stop like fingers in a glove, and you'd still see the cortical ribbon with the vasogenic edema below it. With diffuse gliomas, they frequently invade the overlying cortical ribbon, right, and infiltrate up, and they surround neurons, that's perineuronal satellotosis, surround blood vessels, perivascular satellotosis, collect beneath the pia all the way up to the molecular layer, filling in the molecular layer. That's called subfield growth pattern, and all of those are 3 of the 8 secondary structures of Shearer, which were described in diffuse gliomas. It's screaming diffuse glioma. It is not pathognomonic, but it's highly suggestive. You know it's a diffuse glioma? We know it's an adult. It is an adult, all right? And there's a T2 layer mismatch sign. And in that situation, it's essentially the positive predictive value, 100% astrocyte IDH mutant. Now, I know many of you, like all the neuroradiologists, neuroradiology fellows, and Dr. Harb, I know Dr. Gilbert, have seen this multiple times. This is a brand new case. You haven't seen this case unless you're at MD Anderson, right? I will continue to show these periodically because, again, it's the real world, and until everyone in the conference, you see this, and it's like a gestalt. It's identical, and you start typing in, just T2 flare. That's all you'd have to do. T2 flare MM, right? I will continue presenting them. All right, now here's the thing. The correct answer is not diffuse astrocytoma IDH mutant. It's not. Why? Okay. Dr. Singh also pointed out the remodeling, slow growth remodeling of the overlying intertable of the skull. Thank you, Dr. Singh. Huge. So it's been there a long time. That's another clue. I think this particular tumor, I'm going to get it confused. Man, I can't remember. It's either 10 years, maybe 20 years. We are seeing that we actually are. Now listen, okay, focus. The best diagnosis is not this. Okay, diffuse astrocytoma. Why is diffuse in red? That is the wrong part. The reason why you put something in red, all right, is because, yes, outdated. Octavio, outdated. Why is that wrong? Because diffuse astrocytoma, IDH mutant, is so WHO 2016. I mean, this is last year's model. This is last year's model. You understand? No, what should the diagnosis be? Seriously, you're still using the WHO 2016 classification? Really? With the C-impact updates out there, and the C-impact updates are telling you what the WHO 2020 diagnosis and criteria will be? Yes, Dr. Harb, astrocytoma, IDH mutant. There's no diffuse, there's no anaplastic, there's no glioblastoma. All right, you're going to use a 4-year-old 2016. Well, think about it. 2016, that was put together in 2015, right? All the data, 2015 data comes out in 2016. I mean, we're talking a 5-year-old system. That is a lifetime in contemporary oncologic neuro-oncology. All right, do you like the sarcasm? All right, I'm rubbing it in, so get with it, and get with it now. Now look, if you don't have the C-impact, C-impacts, you're going to be so behind. All right, really, C-impact 6 and 7 are the only 2 you need. You're going to be so behind when the WHO comes out. Why not get ahead now? Now, I am doing my best. I'm just one person to bring you up to speed. That's more sarcasm. All right, here we go. C-impact now, update 6. New entity and diagnostic principal recommendation of C-impact Utrecht meeting on future CNS tumor classification. The future means the WHO 2020, the 5th edition, okay? All right. The most important author, the driver of the paper, has been highlighted with a red box. His assistants are also listed on the paper. I always believe in giving credit to my assistants. Okay, that's obviously not true. Okay, let's look at it. Table 6, suggested definitions and grading of astrocytomas, IDH mutant. Look, astrocytomas, IDH mutant. All right, there we go. Astrocytoma, IDH mutant, WHO grade 2, astrocytoma, IDH mutant, WHO grade 3, astrocytoma, IDH mutant, WHO grade 4. Those are the new diagnoses. What do you not see? You don't see anaplastic astro, you don't see glioblastoma. Those terms will be reserved for IDH wild type disease. All right, 2, 3, and 4. All right, let's look at astrocytoma IDH mutant grade 2. A diffusely infiltrative astrocytoma with an IDH1 or IDH2 mutation, the well-differentiated laxus-like features anaplesia. Mitotic activity is not detected, or it's low, it's still subjective, it's okay. Microvascular proliferation necrosis and CDKN2AB homozygotes are absent. Oh, look at that. We have added a molecular signature in with the two classic histologic features. Can you even do that? I mean, is that legal? To put a molecular signature in with the time-honored, hallowed histologic criteria for grading diffuse astrocytomas? Well, it doesn't matter if it's legal or not, if you like it or not, it is here. What that means is, listen, what that means is a histologic grade 2 diffuse astrocytoma, if it has CDKN2AB homozygous deletion, it is now astrocytoma IDH mutant double grade 4. Same thing for anaplastic astrocytoma of the old days. You know, if you don't have vascular proliferation and necrosis, there's no contrast enhancement, and it has CDKN2AB and no necrosis, no vascular proliferation, has the homozygous deletion grade 4. Isn't that cool? Now you need to internalize it. Now look, let's back up just a second. We're talking about IDH mutant disease. Everyone understand? CDKN2AB mutant, IDH mutant. The reason why I'm saying that is we're going to show very quickly IDH wild type disease and the molecular signature there in just a second. Now at the tumor board this past week, at the tumor board, there was a little bit of confusion about the molecular signature of IDH mutant versus IDH wild type disease. They're completely separate, completely different. So listen, everyone listening to this conference, if you will internalize this right now, I'm really burning it, then you will be an asset, all right, in this immediate future, right? So CDKN2AB, this is IDH mutant. Okay, what's astrocytoma IDH mutant grade 3, diffusely infiltrated astrocytic glioma with IDH1, IDH2 mutation that exhibits focal or dispersed anaplesia and displays activity, mitotic activity. I don't think that this focal dispersed anaplesia is really, listen, honestly, I used to call them bland cell, all right, bland cell, glioblastoma even. I honestly don't think that's an essential criterion because they can be very monotonous, but with a significant mitotic activity, of course you're going to bump it if it's a diffuse astrocytoma. All right, microvascular proliferation necrosis are absent, all right, obviously. And then finally, tying it all together, grade 4, diffusely infiltrated astrocytic glioma, IDH or IDH2 mutation exhibits microvascular proliferation or necrosis or anyone homozygous deletion, then you bump it to a 4. Okay, everyone got that? New world. Now listen, most people wanted to eliminate histologic grading altogether for IDH mutant disease. Not altogether, not for grade 4, but for grade 2 and grade 3, because it is an extremely poor predictor. And actually grade 4 is an extremely poor predictor. Listen, anecdotal, ready for an anecdote, which was yesterday, maybe today too. There's a current patient who I think it was some 20 years ago was diagnosed with glioblastoma, WHO grade 4, 20 years ago. And the patient has a little bit of non-enhancing, maybe just a tiny bit of enhancing disease now. That's histologic criteria for you. Now, obviously, this is an IDH mutant diffuse astrocytoma. It was called grade 4 because there was a little bit, I believe, of vascular proliferation unassociated probably with the other yada yada. Everyone understand? That case is not rare. Anaplastic astrocytoma 15, 20 years ago, still here, still not contrast enhancing. We're seeing it regularly. And now we understand why, at least for a subset of cases, it's IDH mutant disease. Everyone got that? Yeah, just think about it, ponder, if you will. There's a whole table, all right? What about IDH wild type? We'll go through this quickly because there's also a change. Here are the names. Diffuse astrocytoma IDH wild type grade 2, anaplastic astrocytoma wild type grade 3, glioblastoma IDH wild type grade 4. We're going to keep glioblastoma and NAA for IDH wild type disease. Again, let's go to the C-Impact Update 6, and here are the criteria. IDH wild type diffuse astrocytoma, this is for calling glioblastoma IDH wild type grade 4. It will be IDH wild type number 1, diffuse astrocytoma number 2. It doesn't say adult, but for both the IDH mutants, we're talking about adult tumors. Pediatric diffuse gliomas, completely different story, right? We're not talking about that now. These are adults. Internalize that. So we have a diffuse astrocytic glioma that's IDH wild type, wild type, and we see either microvascular proliferation or necrosis. We can call it glioblastoma grade 4. That's exactly what we're doing right now under WHO 2016, and we're also doing under WHO 2007, and I think we changed up. So 2000 is when we stopped requiring necrosis and would allow vascular proliferation. That's what we have right now. So what is new? Or one or more of the following features. TERT promoter mutation. Now, no, look, pay attention to this first. Listen, please. TERT promoter mutation. It doesn't say TERT coding sequence, TERT gene mutation, the coding sequence. It's the promoter specifically, and there are two canonical, all right, sites which give the biology, right? Or EGFR amplification, not mutation, it's an amplification, or gain of 7, loss of 10. Let's go back to the TERT promoter mutation for just a second. The reason why I emphasize that, listen, not all NGS, next generation sequencing platforms, analyze the promoter region. Some only analyze the exons, the coding sequence. There are TERT gene mutations in coding sequence. They do not have the connotation, the impact. They may have other impact, but not this. It has to be the promoter. What does that mean? It means, let's say that you leave today and you go to you finish your training, you're at the new hospital, and you look at your NGS report, comes back, whatever platform, and it says TERT mutation. You have to follow that up and look at the details. Exactly what, all right? And it has to be one of the two canonicals. Got it? Okay, so here we go. This is a comparison. Look at this. Table 5 and Table 6, all right, from update 6. IDH wild type, look at the red. IDH wild type, TERT, EGFR, gain of 7, loss of 10. IDH mutant, CDK2 and AB. Everybody got it? Take just 1 second and burn your brain. Do not confuse IDH wild type and mutant. Got it? I know. You know what one of the big foibles of pathologists is? I don't know if radiologists are like this or not. Pathologists, one of our biggest character flaws, we tend to over-explain everything. All right, my wonderful wife, Tina, will say, she will ask me a question for which I could give a 2-word response, and I'm going to take 15 minutes because I'm going to explore every facet. Anyway, all right, let's move on. Here's the point. Neuro-oncology has moved into the era of molecular signature determined grade for certain brain tumor types, such as diffuse astrocytic disease. That is huge, and we are leading the charge with putting the signature in the name when it is clinically warranted. All right, you want to go to patient number 1? I only have 1 patient, so this is it. I mean, we're going to conclude the conference. Okay, with this. I have 1 patient. Patient 1, 16-year-old female. All right, there's the data. But there's something special. There's something special. Now, I'm going to use this patient to introduce a new conference feature. And this conference feature is going to run from today, until the 5th edition of the WHO 2020 is officially released. Okay, and then we'll slightly change it. Can you guess what it's going to be? It's the new entities. We are going to review, to the best of my ability, each week that we have the conference. I'm going to present 1 new entity that will be in the WHO 2020, okay? And most of this is based on the C impact, yada, yada, yada. Everybody got it? Is that exciting or what? It's huge. Why would you not want to leg up? Here it is. This is the new entity. Okay, I'm going to wait. Let's see if someone can get the new entity, or just a molecular signature. I will accept new entity. Yeah, Dr. Gilbert got it. Exactly right. I want molecular signature. Yes. Gosh, Giselle Lopez. Duke University. That's my alma mater. Absolutely. Okay, Octavio. No, there's a huge thing, Octavio. This is the best thing that could happen to you this conference today, because you're going to learn something new about the thalamic gliomas. Now, look, you know what? When you're right, that may feel good for a minute. It's a waste of time. It's a waste of your time because you've learned nothing when you're right. The only time you learn is when you're wrong. And that's why you need to be wrong. And Octavio, that's why kudos to you for putting it out there. All right. And the answer was histone H3K27M mutant, diffuse midline glioma H3K27M mutant, which we associate with a big subset, not all, but a large subset of thalamic gliomas. That is exactly correct. It is a midline structure, the pineal, et cetera, but not in this instance. Now the game has changed. And if you didn't know that, because the key here is bithalamic. Now let me say what I mean by bithalamic. Yeah, it's a little bit asymmetric. right? Bithalamic does not mean a unithalamic glioma that crawls across the massa intermedia, the gray commissure, and gets a foothold in the contralateral thalamus. It doesn't mean that. That can happen. And the thalamic gliomas, they also go rostral into the basal ganglia. They can go into the temporal lobe. They can go posterior. But the epicenter is in the unilateral thalamus in H3K27 diffuse midline glioma. In bilateral thalamic, there has to be major, predominant, significant involvement at presentation, at clinical presentation of both thalami. Now, it can be like this. This is perfect. It's asymmetric, but that is a huge chunk of that. Everybody understand what I'm saying here? It has to be more or less equal. It's like at presentation, it's the same. It's not primarily predominant. Now, I'm going to say, let me say right off the bat, for anyone who may know, there are rare exceptions of all the bithalamic gliomas which have been analyzed to date. There are a few, a handful, tiny, that do have histone H3K27 mutation. That's fine. But they also have the hallmark mutation that we're going to talk about. Okay, everybody got that? Yes. Okay. Yes, and Dr. Harb is correct. There's actually two types. All right, this is the name of the tumor. Bithalamic glioma, EGFR mutant. This is the name of the tumor. If you are not familiar with it, absorb it right now. If oncologic neuropathology is important to you, absorb this tumor right now, okay? Let's look at the characteristics. What are the characteristics of the tumor? Typically arises in childhood, adolescence. There can be exceptions in adults, etc. Typically childhood into adolescence. All right, look at this. I showed the coronal down here, T2 flare coronal. All right, diffuse astrocytic tumor. Major involvement of both thalami at clinical presentation. Major both clinical presentation. Everybody got that? And you can usually determine for most cases. Now you might argue, well, if it spreads through the massa, maybe when we're talking clinical presentation, all right, not a few years down the road. If the patient lives a few years, this is a grade 4 tumor. I could have added up to a grade 4. This is a grade 4 tumor. All right. Recurrent genomic alteration is EGFR mutation. All right, let's get, oh, look at these double colons. That is a faux pas. I sincerely apologize for that. I will do penance somehow. Okay, recurrent genomic alteration, EGFR mutation. Let's get granular because that is what we do in this conference. Remember a few weeks, maybe a month or two back, it may have been even, I think it was pre-COVID, we took a case where the Oncomine or the solid tumor genomic assay .2018, which is the NGS platform that we use Oncomine V3 that we use at MD Anderson Cancer Center. We look at the visual display, an EGFR gene was circled, meaning there's a EGFR alteration. And we talked about all the different alterations. There could be amplification, point mutation, inversions, insertions, the EGFR V1, V2, V3, V4, or V5 alterations. There are two. Listen, there are two different alterations. One is predominant. Let's look at both of them. The most common are small in-frame insertions in exon 20, which encodes the intracellular tyrosine kinase domain. Now that's why this is the one, because it's at the active site and it's going to constitutively activate the tyrosine kinase. That's where the oncogenicity comes in. Okay. And the second is missense mutation within exon 7. And exon 7 encodes the extracellular ligand binding domain. Do you know of any other alteration in EGFR major that involves the extracellular domain? Oh yeah, that would be EGFR V3, all right, with deletion of a big chunk of the extracellular domain, which again leads to constitutive, which means continual running, all right, engine running wild, no break, activation, all right, of the tyrosine kinase and the oncogenicity. All right, see, I want you to understand. See, if you understand it, then you don't have to memorize things. Memorization will ultimately fail you. Understanding will last a lifetime. And how much better, listen, how much better of a teacher are you if you understand the mechanism, the reason, and you can explain that to students, or you quiz them and you explain it to students, than just memorize this list, this set of facts, this set of, the male-female ratio is, and the incidence, per 100,000 is. Huh? Okay, you like that? All right, let's look at this is one of the big papers, several papers out there. Check this out. This is active neuropathologic. Check out the date when this is published, 2 months ago. Now, there was data in the literature before this, but this is the one that nailed it. Okay, and you can see it's cast to thousands. All right, pediatric bithalamic gliomas have a distinct epigenetic signature of frequent EGFR exon 20 insertions, resulting in potential sensitivity to target kinase inhibition. Now, look, that's the other huge story. The other huge story is because it's EGFR, because that is the driver, right? Activation of EGFR, the tyrosine kinase, then it's targetable, potentially targetable. Now, imagine this. Imagine this if you're a neuroradiologist. Oh, my goodness. You're a neuroradiologist. A new case of this comes across your desk, a child with bithalamic glioma. The first thing you should think of is targeted kinase inhibition treatment, helping the child. That's what should come to your mind. All the steps in between. But that is the bottom line. And that is why we do what we do, is to help the primary care physicians, the neuro-oncologists, the radiation oncologists, the neurosurgeons do the best job they can to help the patient. This is hugely powerful. You like that? All right, listen, these are the figures from the paper. All right, look at the case up here. Isn't that drug? This is a T2 flare. Isn't that gorgeous? It looks very similar to our case. It's a kind of an asymmetric. We used to call these, by the way, thalamic mirror gliomas, and they can occur in the hemisphere as well. It's an amazing thing. We'll present those at some point. Patient number 3 is 11-year-old, all right, female, EGFR exon 20 insertion. IDS wild type. Look at the histology. It's just a diffuse astrocytoma, right? You see them day in, day out. You know what diffuse astrocytoma looks like. Here is the H3K27M mutant protein, and you see just a hematoxylin, stone cold negative. All right, again, there are a few rare exceptions, but usually not. That is not the driver, and the rare exceptions always have this driver. Okay, now let's. I want to only look. There are 13 patients in this series. They had 13 patients series. That's why so many co-authors. They got tissue from everyone they could get an example of. It's a rare tumor. That's how you do it. Got it? Let's look first at sex. I'm not really talking about sex. I'm talking about gender. I like gender. People say, you can't use gender because you can have gender reassignment, yada, yada, yada. I guess we could call it X and XY chromosome status. That's what we call it, XY chromosome status. All right, if you can see male predominant, all right, but also female. Now, honestly, I would be very careful about saying male predominant, and it doesn't matter anyway, because there are 3 females, which means it could be either. That's not hugely helpful. Also, why do I say be careful? Because right now, we've got maybe, less than 50 for sure, less than 30. I'm not sure sequence. Wait until we have 200, or at least 100. Wait till we have 100 patients before you generalize that. The literature, listen, the literature is replete with examples of the first paper, the first series, claiming a highly characteristic feature, which is not supported once you have 100 patients. Example, pleomorphic xantho astrocytoma. The majority do not have xantho cells. In fact, it's striking, it's fun, it's exhilarating to the oncology neuropathologist when you get a PXA that actually has beautiful xanthoma cells. In the others, maybe you'll hunt, find one cell with a couple bubbles in cytoplasm, and then you put that into your boilerplate. Xanthoma, come on, give me a break, right? But that was Dr. Kepish, the legendary John Kepish, Kansas City, who described PXA. In his series, he had an overrepresentation of cases with very prominent xanthoma cells, and he put it into the name. Now, it does not diminish at all the significance of that historic seminal finding, all right? But you have to involve the changes. Okay, that was just a caveat. Look, this is one thing. This is worthwhile. The discussion we're having is worthwhile. And you can say, well, look, there he goes again. He's digressed off into PXA and all that stuff. Look, I could have just shown you and said something like this. There's a male predominance. You've seen these lectures, right? This sort of thing. And they go on and on. And it's like, just get me out of here, right? I want to talk about the principle. The principle here is in a new entity with relatively few cases, take all the character features with a grain of salt, and do not let the absence of any one given feature early on dissuade you from considering the entity high in your differential diagnosis if other features are there. Okay, fine. All right, now this was an exclusively childhood series. Our particular patient was 6, it was adolescent. Certainly there are examples in adolescent. Look at the histology. Okay, you have this, I call it tree green is anaplastic astrocytoma. So most of these were diffuse astros with mitotic figures. That's what that means. Look at the light green. That would be low grade, grade 2. No, that all it means is no mitotic figures. Look, where's the tumor located? In bilateral thalamus. Neurosurgeon, are you going to resect a thalamus? Really? No, probably stereotactic biopsy is going to be my guess. That's why if you don't have mitoses, histologically it's a 2. If you have mitoses, you bump it to a 3. This is irrelevant, doesn't matter. Okay, and then the really dark green glioblastoma. Okay, so maybe there was a case that obviously had some enhancement, maybe vascular proliferation, but that's a rarity. Usually they're going to be non-enhancing, so they're not going to have necrosis or vascular proliferation. If they did, they would be glioblastoma. Got it? See, there's only one example. Okay, moving on. All right, here's where the fun goes. Okay, these are genetic alterations. Look at this. And you see the 20? That's going to be exon 20, 20, 20, 20, 20. And there's one that was actually amplification. But see that bright red? Look at the key over here. That's the activating mutation. So that's what we were talking about, okay? The activating mutation. Here's a PDGFRA. There's amplification. Hold on just a second. What is actually common? Look at TP53, all right? And that's inactivating mutation. So if you just gestalt this table, here's the way to do it. Don't go crazy looking at all the squares and look at the genes. What you do is you look at all of these concurrent mutations, or everything's been reported. And this is the way cancer works. There are always going to be cases. And if you have NGS, you have a case that comes through, it would not be surprising at all if you get one of these, you work it up, and lo and behold, there's a P10. So then we'll color this in for P10. Like some of these rare ones, look at this. All right, PREB-BP, right here, a single case, all right? LZTR1, it's a single case, fine. Here's what you do. You just gestalt it and see where the most common recurrent mutation. What are they? Well, EGFR, that's what it's named for. Look at TP53, extremely common, all right? I mean, even maybe a majority, more than half, not all, sure. What that means is, look, bithalamic glioma, TP53 mutation, what you would say if that turns up, you'd say, and you can do that with immunohistochemistry. Remember, by immunohistochemistry, if 95% of the nuclei are 4+ positive, that is highly correlated with TP53 mutation, not 5%. Or fewer, but yeah, and so that's nice. Now it doesn't give you the diagnosis because you have to demonstrate that the specific recurrent alteration in EGFR, one of the two. All right, in order to, but this is supported data, which gives you 24 hours after surgery, or 448. I guess you have to wait for the H&Es. Okay, you got that, and then you can see a few others, like BCOR, etc. All right, but you can see primarily out of all these genes what the driver is. Okay, again, more thing. Now let's look at the gene. This is the gene up top, EGFR gene. All right, you can see the exons going from 1 on here to 28. Now, very important. Look at here, 17T. That's the transmembrane domain. Look at the key below here. So this dark green, this forest green is the transmembrane. The receptor domain is to the left. All right, so all the exons are numbered from the receptor. Back, transdomain, and then here's the tyrosine kinase, which is in the cytoplasm. Got it? And now the triangles, and these are all the different domains of the external domains, all the different functions and what they're named for, et cetera, et cetera. Now look, the black triangles are all of the alterations in this series of 13 patients that have been identified. The reason why they only put the exon 20, so here's exon 20, and you can see 20 goes from here to here, and look, all the arrows are right there, just catching right into 20. The reason why they only put 20, all right, and not the exon 7 out here, is because that's predominant. That's the majority, but not all. There's a couple, and both of these. Now, how common is that? That's very common, just in diseases in general, not just cancer. Down syndrome, for example, is that you can have different pathways that may converge. They lead to the same thing ultimately, and it's no different for bithalamic glioma, EGFR mutated. Okay, you like that? All right, now that's explained. And see, isn't it nice to kind of understand? You understand the diagram, understand what's going on. Now, hopefully, whether you're a neuroradiologist or a general oncologic pathologist or a pathologist doing general practice, now you are empowered with knowledge, not just memorization of facts. All right, this is my intention. Like I said, every conference I give, I think we're off next week. Yeah, we are definitely no conference next week. Spread the word because I'm on service. That's the only reason. Then we will pick up, I think for the next 2 or maybe 3 in a row. I will be doing the conference. You should receive an invitation. If you have friends who complain they did not receive the invitation, I'm going to edit the list We may go to Zoom next week, et cetera, and I'll make sure everyone's included. Okay, and with that, I'll say thank you. I have not made a Twitter or YouTube post since COVID hit, but I'm preparing for a magnificent return. Thank you very much for attending. Thank you to everyone who stayed to the bitter end. And it wouldn't be a conference without you. I am truly appreciative, and I hope you had fun. That concludes the conference. So I will see you in 2 weeks. Bye.